be higher depending upon the stakes of the procedure. Obviously, AFib ablation has risks, and the frequency with which the disease occurs, the prevalence of AFib is very common. So the size of the population is large, and the risks are high, and the costs are high, so the stakes are high for AFib ablation. Now, in the United States, what you can see is that we have a baby boom generation, some 75 million people born between 1946 and 1964, who are now getting into their 60s and causing a much higher frequency of AFib. It's going to be 12 million people by 2020, and it's costing us currently about $26 billion a year. And in this context, we have many goals. We want to reduce the risk of stroke with anticoagulation, and we want to alleviate symptoms as well with rhythm control or rate control. And the primary decision about rhythm control versus rate control is based on symptoms. Now, when we do decide to control the rhythm, which we do in roughly 40% of patients, we have two options: antiarrhythmic drugs or catheter ablation. Increasingly, we have another option, which we alluded to this morning, which is lifestyle intervention, because there's good data now from prospective randomized trial that lifestyle intervention can decrease the frequency of AFib. And to get right to the chase on this, a 10% reduction in body weight results in a 50% reduction in the risk of atrial fibrillation. Lifestyle interventions that come from typically outside the domain of medicine. Now, there's many types of AFib. There's paroxysmal, there's persistent, and there's permanent. And there are many types of symptoms. And there's a very good classification scheme that goes from asymptomatic, class 0, to severely symptomatic. And we need to be mindful of this, that the type of AFib and the symptoms vary by the individualized patient. And in this respect, with the three goals, rate control, maintenance of sinus rhythm, and stroke prevention, we need to look very specifically at the type of AFib: paroxysmal, persistent, or permanent. And we need to look very, very carefully at the symptoms they have, all the way from asymptomatic, class 0, to severe symptoms, class 4. We use clinical trials to tell us what we can do. Prospective data gives us the best available scientific agent. We use guidelines to tell us what we should do, but importantly, we use registries to tell us what we're actually doing and how we're performing what we're actually doing. And in this respect, we do have ablation registries that are now being developed by the American College of Cardiology that clearly have limitations, but can allow us at least to tell us how well the patients that we're ablating do compared to the clinical trials, how they do in long-term follow-up, and whether there's centers and individuals that actually do the procedures with lower risks and better outcomes than other centers. So these are the guidelines that are used in the United States. They're developed in 2014. The ESC, the Canadian College of Cardiology, has them as well. And these are all available to all of you at any time. Now, if we look at the efficacy of antiarrhythmic drugs in AFib trials, they actually don't do very well. You can see that amiodarone has success rates long-term of about 65%, but the other drugs, sotalol, dronedarone, don't do very well compared to placebo. So retrospective analyses show that the drugs don't work that well in the long run. Based on this, now in the late 1990s, Michel Hasseguer in the New England Journal of Medicine published this study where he actually went in and ablated the pulmonary veins. Now, in his early reports, he noted that most of the episodes of AFib in patients with paroxysmal AFib were coming from one of the four major left atrial pulmonary veins. And by going on to ablate those areas, he could actually eliminate the AFib. This was really a paradigm shift in AFib, and it's gone on to develop a cottage industry in which we'll isolate, either with radiofrequency, cryo, or even surgically, the pulmonary veins, thereby eliminating the source of the atrial fibrillation with outcomes data that are reasonably good. Now, if we look at single procedure success rates off antiarrhythmic drugs, the data that's available is shown here in a relatively recent, now 5-year-old meta-analysis. I've collapsed this data down to a single slide to show you, that if you look at single procedure success rates with AFib ablation using radiofrequency, it's about 60%. In multiple procedures, you can get up to about 70, 75%. By contrast, antiarrhythmic drugs don't work as well. These are not randomized trials. These are retrospective analyses of other trials. So there's lots of limits to this data. But the single procedure success rates are as noted. This is an important point because it determines the fact that many of these patients who had ablations actually continued on antiarrhythmic drugs. So many patients in these old trials continued on antiarrhythmic drugs. So it's not antiarrhythmic drugs versus ablation. It's antiarrhythmic drugs versus ablation plus the drugs. We'd expect the ablation groups to do better. So what really matters here is the prospective randomized trials. The MANTRA trial was one such trial enrolling just under 300 patients, looking at ablation versus drug therapy, and they concluded long-term that the ablation worked better than drug therapy. A second trial was the RAAFT trial, and this also concluded that ablation works better than drug therapy. In fact, if one looks at all of these trials, there are now only 5 of them that have prospectively randomized patients, including the MANTRA, RAAFT-1, RAAFT-2, and 2 other publications, looking at outcomes. I've collapsed this data into this single slide, showing here that ablation works better than antiarrhythmic drugs in these prospective trials, but there are many limitations to this. One of the limitations is that these trials use patients who are very young. These patients typically were younger than age 60. Most of the AFib occurs in patients over age 50. The longest follow-up of any of these trials was 18 months, and we now know that out at 5 years, at least a third of these patients have recurrences of the AFib. So if we look at a large registry, the discern AFib with more than one ablation procedure was done in about a third of patients. This is a retrospective registry. What they found, the success rate was about 50% for AFib ablations, much lower than in the prospective randomized trial. These were symptomatically free of AFib. So when we do the ablations, many people have a placebo effect, or they have less frequent AFib or slower AFib, so they develop fewer symptoms. But the ratio of asymptomatic to symptomatic AFib increased from 1 to 3.7. So about 3 times as many patients after the AFib ablation are asymptomatic despite having recurrences of it. So many, many limitations to looking at symptomatic recurrences of AFib because symptoms underestimate the burden of AFib with 12% of patients having asymptomatic recurrences only. So there is clearly some degree of placebo effect with the surgery itself. So catheter ablation was found to be superior to antiarrhythmic drugs for maintaining sinus rhythm in a very small group of randomized patients, but these are patients in whom antiarrhythmic drugs had failed. Many of these patients still were antiarrhythmic drugs. There's no good long-term follow-up data. But the question is, has ablation received sufficient efficacy to be considered first line for all patients with paroxysmal AFib? And let's take a look at the complication rates. Well, if we look at the complication rates from AFib ablations, they're shown here to be in the range of about 10%. Antiarrhythmic drugs also have complication rates, as we all know, intolerance that requires discontinuation. If we look at data from large registries with over 4,000 patients, we can see vascular complications, hematomas, perforations of tamponade, all of which are reversible. What's not reversible is stroke. It's about a 0.24% risk of stroke in these individuals. Now, interestingly, some data at how to be safer has come out of this and how to be more effective. So in these trials, what we found is that if you isolate the pulmonary veins, that you're more successful. So isolation of the pulmonary veins has come out of these trials as being a critical component of it. And in terms of safety as opposed to efficacy, what we found is that if we use intracardiac ice, it's also much more effective as well. Now, what about costs? Well, there's been one study that's looked at the modeled cost of AFib ablation versus antiarrhythmic drugs, and it's basically concluded at 2 years of follow-up, there's no difference in medical therapy versus the ablation. Now, the ablation up front, of course, has higher costs, with the procedure cost being about $10,500 US. What's not considered here is the fact that at 5 years of follow-up, at least a third of the patients who had prior ablations are going to require a second procedure. So many, many limitations to the cost data, as there are limitations to the available data relative to the efficacy and safety of the two techniques. So there's a recent consensus statement that concluded that catheter ablation is a reasonable option for patients with symptomatic PAF before therapy with antiarrhythmic drugs. Now, this data has got to be put into the appropriate context, because whether this catheter ablation is possible or useful in many patients is part of the issue, but another part is whether it should be used as first-line therapy. And I think based on the available evidence, it's very, very clear that there's a very small subgroup of patients, those with paroxysmal AFib, in the absence of any structural heart disease, who for one reason or another decline antiarrhythmic therapy, who may be candidates for AFib ablation as first line. And indeed, if we look at all of the guidelines, this happens to be an algorithm from the Canadian Cardiovascular Society, the American Heart Association, the European Society of Cardiology, essentially have the same guidelines. And what we're looking at is symptomatic AFib, shown up here on the left side, in whom they have a low burden, you give them pill in the pocket. If they have a high burden, you use an antiarrhythmic agent, and then go on to catheter ablation. So the standard of therapy in patients with atrial fibrillation is to try to maintain sinus rhythm with an antiarrhythmic drug, and if they fail, then consider catheter ablation. When we look at the entire spectrum of atrial fibrillation, as shown here, there's a very, very, very limited role of AFib ablation in those individuals who have permanent atrial fibrillation. Success rates are low, 50-50 at best, and because these patients tend to have more heart failure, more dilated left atria, commonly with mitral valve disease, the risk of the surgery goes up. So AFib ablation is reserved for patients who have failed at least one and ideally two antiarrhythmic drugs with permanent AFib. If they have persistent atrial fibrillation, they really should have an antiarrhythmic drug before they go on to an ablation. And it's a very small group of individuals, perhaps less than 5% of all patients with the paroxysmal AFib, in whom AFib ablation should be considered as first-line therapy, with a very clear indication that the patient should be informed about the potential risk of the therapy relative to the benefits of the therapy. And frankly, in most of these patients put on very low doses of an antiarrhythmic drug twice daily, they'd have very, very little or no atrial fibrillation. So I preface this talk by saying that the options of antiarrhythmic drug versus ablation need to be considered in the context of new data. And we need additional data very clearly about ablation versus antiarrhythmic drugs. And we will be getting this data through 3 large prospective trials that are currently enrolling patients, looking at mortality endpoints and randomizing patients themselves. And these 3 trials are going to have a profound impact on the way that we use AFib ablation as we move forward. But I had the privilege of chairing for the American Heart Association a research summit now 4 years ago, in which we looked at ways in which we could ideally try to address this emerging burden of atrial fibrillation. And one of the major conclusions that we reached was that we need to go on to primordial prevention. Now, what does primordial prevention mean? It means the prevention of development of risk factors for atrial fibrillation. And as I alluded to earlier today, the very same risk factors that predispose to AFib, predispose to coronary artery disease and stroke, myocardial infarctions, sudden cardiac death. It is diabetes and hypertension, which cause lipid profile changes and cause remodeling of the left atrium that predispose to it. Now, we've looked very, very hard with a number of upstream therapies for prevention of AFib. We're only starting to get data about primordial prevention. Unfortunately, we have not been successful with trials looking at primary prevention. Once the individuals have risk factors, intervening with ACEs, ARBs, statins, corticosteroids, or colchicine, These studies are largely negative. Secondary preventions are what we're talking about, antiarrhythmic agents versus ablation. But there's a missed opportunity here that I want to emphasize to all of you because I think it will impact profoundly on the way that you leave this conference and treat your patients. And this really has to do with some data, primordial prevention of risk factors, prevention of obesity, hypertension that predispose to atrial fibrillation. And I wanted to show you this data. It's data that's now been reproduced in 2 additional studies looking at the effect of weight reduction and cardiometabolic risk factors on symptom severity management in patients with AFib. So patients with obesity and hypertension who had symptomatic AFib. And these patients were randomized into a trial in which they had antiarrhythmic drugs, and if they failed, onto ablation versus weight reduction and exercise. Now, how did they lose weight and how did they exercise? They did it in a structured program that included nutritionists and exercise physiologists. This is outside of the domain that physicians are competent in doing. So it has to be in a center that focuses on these kinds of things. And in these individuals who on the average lost 10% of their body weight in 6 months, guess what? Their BMIs went down, the frequency of AFib went down, their abdominal weight went down, and if you take the lower right-hand corner, if you look at patients on antiarrhythmic drugs versus weight reduction, those who also had ablations versus weight reduction, the symptom burden improved much more dramatically in those who had weight reduction with 10% of the total body weight. And by the way, you not only get the benefit of symptom improvement and decreased AFib, but of course an improvement in lipid profiles, improvement in diabetes profile, hypertension profile, which we think in the long run is also going to result in improvement in long-term outcomes relative to stroke, relative to coronary artery disease, peripheral vascular disease as well. And of course, all these patients at baseline had to agree to quit smoking. So there's a big message here, is that we're working at the end stage of a disease, hypertension, obesity, contributing to left atrial dilatation and AFib. And we've got to start thinking a little bit more long-term. These were patients with metabolic syndrome and whom intervention in their ages 50s and 60s resulted in a decrease. Imagine what we could do if we started at age 10 and 15 and 20 in terms of prevention of coronary disease. So this was published in JAMA in 2013 by an Australian group. It is a remarkable piece of data that we all need to be mindful of because so frequently we're working at the other end of the spectrum. So in the remaining 20 seconds, what I'd like to do is to just thank you for your attention and be very glad to take any comments or questions perhaps at the end of the session. Thank you.